Good day, everyone. Thank you so much for joining this new session of the epilepsy surgery teaching webinar. We are extremely excited to have here both Christian and Valerie to discuss such an important issue as to the extent of resection in temporal lobe epilepsy, which is still the most prevalent epilepsy surgery procedure. This webinar is part of our teaching sessions that comes about every first Sunday of the month and is co-sponsored by the International Epilepsy Surgery Society and the World Federation of Neurosurgical Societies. So without further delay, I see both of our guests ready to go, and I would like to invite Christian Dorfer from Vienna to start speaking on hippocampal sclerosis and the extent of resection. The dynamics of this webinar is we are going to have two presentations up to 30 minutes, and then we have additional 30 minutes exclusively for debate and questions. You could put your questions in the chat or in the question box, and we will definitely address any of your concerns or questions. So Christian, would you please go ahead and start your presentation?
Sure. Thank you very much, Arthur. I'm happy to start this webinar with the topic on hippocampal sclerosis and the extent of resection. And in our last webinar, we heard a lot about temporal lobe anatomy and also temporal mesial anatomy. And within this talk, I'm going to talk a lot about hippocampus anatomy, histology, approaches, and what is the extent of resection and its impact on seizure outcome and also memory outcome. Before we start with surgery, quick introduction into the histology of the hippocampus. You probably know that the hippocampus can be divided into subdivisions, the cornu ammonis 1, 2, 3, and 4, and then the gyrus with his two separate areas. And hippocampal sclerosis is very nicely defined by the International League Against Epilepsy based on the neuronal loss within the hippocampus. So type 1 would be neuronal loss in all of the subdivisions. Type 2 would be neuronal loss more in CA1 than in CA4. And type 3 would be neuronal loss more in CA4 than in CA1. And then there's also gliosis only. And on MRI, this also gives us a very typical appearance. As you can see here, we see volume loss. If we compare it to the left, we see that the internal structure is lost, as you can see here, as when you compare it to a healthy hippocampus, and also here. So the internal structure is diminished. There's a volume loss and also a signal change. The hippocampus, as you can see here, is embedded in a lot of other different structures that all are important for seizure generation or seizure propagation. And these are the temporal polar cortex, the piriform cortex, the perirhinal and entorhinal cortex, also the parahippocampal cortex, and the amygdala as another nucleus. And all of these have importance in the individual patient to a different extent also. And the discussion is what needs to be resected. How often do we face hippocampal sclerosis? As you can see here in this publication with 10,000 patients, it's the most prevalent indication for temporal lobe epilepsy surgery, giving over 1/3 of the patients. What about surgical approaches? As you can see here, we are facing the hippocampus, that's the amygdala, the parahippocampus. And then you can approach this by resecting the tip of the temporal bone, which is the Spencer technique that we saw in our last webinar. And you can also approach it through the temporal lobe, the transcortical approach. You can approach it from underneath the temporal lobe, which is the subtemporal approach. And you can also approach it through the Sylvian fissure, which is the trans-Sylvian approach. And which approach is better or not is a very, let's say, subjective and based on the experience of the individual institution and the individual surgeon. There is no better than the other, I would say. And the trans-Sylvian approach is the approach that I have learned and that I am performing. And this is how I position my patients. The upper body needs to be elevated to have a relaxed brain, and I brace them on both sides to be able to get all of the angles that I need for later resection. Skin incision is very typical. One word to the craniotomy. What is important if you're right-handed to have this area fully exposed, because you would need this later in your trajectory along the hippocampus, and also the dural opening, as you can see here in a standard fashion. Just a short video to show you this. So we have opened the Sylvian fissure here. We have opened the temporal horn. We are opening it to the posterior part of it, and then we want to detach the choroid plexus from the hippocampus to be able to detach the caudal artery and the optic tract. I'm using paddies here, as you can see. So this is the hippocampus. With the paddy, I'm detaching the choroid plexus C and opening up the caudal fissure as depicted here. Again, with more zoom, detaching the hippocampus from the choroid plexus. The choroid plexus is hidden underneath the section here to open up the caudal fissure, which is an important step. And then we are facing the hippocampus head here. 3 cuts: the lateral cut, the medial cut, and the posterior cut to resect the hippocampus. Also familiarize yourself before surgery about the anatomy of the temporal mesial structure, especially the collateral sulcus, which is an important landmark through your resection. And there is quite a variation in this collateral sulcus and also the other systems. So as you can see here, this is the lateral cut through lateral to the hippocampus. As you can see here, I usually use a dissector as depicted here, and you continue this dissection until you identify here the arachnoid plane of the collateral sulcus, which is your anatomic landmark for the lateral border of your resection. Then the posterior cut. I tried to get as posterior as possible. We can discuss later if this is relevant or not. And I use this curved dissector to get as posteriorly as possible for this posterior cut through the hippocampus. And last but not least, the medial cut. We have opened up here the caudal fissure, and we are continuing the resection here until the hippocampus is completely dissected from its arachnoid sheet. And I will move this a little bit forward, because then comes the part where we need to identify the arteries and veins that go into the hippocampal sulcus, and we need to dissect them and separately coagulate and cut them. You have the arachnoid plane here of the temporal base, continues here to the collateral sulcus, some remaining vessels going into the hippocampal sulcus to be able to dissect the parahippocampus, which is beneath the hippocampal sulcus, And last, if you have dissected all of it, you can resect the hippocampus in one piece. So what about the need of the extent of hippocampal resection? As you probably know, the hippocampus can be divided into the hippocampus head, the hippocampus body, and the hippocampus tail. You see this here in the axial view and here in the sagittal view. And there was a very nice study done by Johannes Schramm from Bonn, where they randomized the extent of resection 2.5 centimeters versus 3.5 centimeters. And from their results, there was no difference in seizure outcome, whether you did a smaller or larger resection of the hippocampus. What about memory outcome with respect to resection length? As you can see here, hippocampal volume had an impact on the left side for verbal memory and verbal learning, and the hippocampal volume had an impact on the right side on figural learning. What is important here, this is all related to the hippocampal volume, but not the resection length, which makes sense because it's not so critical how long your hippocampus is, but the volume of the hippocampus, because if you have a small volume of the hippocampus, a very sclerotic hippocampus, then also this hippocampus does not have any function. Then let's dig into, let's say, some historical series, trying to define what is the extent of hippocampal resection. So this is from 1991 from William Feindl, where they did an amygdalectomy with minimal hippocampal resection, review of 100 cases. And as you can see, only 21 patients got seizure-free, meaning that hippocampal resection is key. The opposite results of and resection technique that spares the amygdala but resects the hippocampus. And here you can see that seizure outcome is way better. So it's clear that the hippocampus is the most important denominator of seizure generation and needs to be resected. But still, the question is open, what actually the extent, to which extent it's necessary. And then Guy McCann tried to individualize the extent of hippocampal resection by doing intraoperative electrocorticography of the hippocampus. And what they saw is that in those patients that had residual spikes on intraoperative electrocorticography had worse seizure outcome. But what is also very interesting to see within these two cohorts, you see here class 1 seizure-free and class 2-3 non-seizure-free, the hippocampal resection in millimeter between these groups is quite similar, if not the same. So again, the length itself does not matter too much. And then very a recent publication, 2024 in Nature Medicine, where a group tried to identify the fasciolar cinerarium, which is here at the hippocampal tail, as a potential interventional target in epilepsy. And it's a very comprehensive paper where they evaluated not only in human, but also in rodents. I will just refer to the human and patient examples that they were given. So what they basically did, they did SEG. You see here the hippocampus head, body of the hippocampus, and the tail of the hippocampus in blue. And what they saw in these patients is that the posterior hippocampus, the fasciolar cinerarium, in this patient was involved in 100%, in this patient to a very great extent. In another patient, 100% involvement of the hippocampal tail, and also in this fourth patient, 100% involvement of the hippocampal tail in seizure generation, not propagation. And this is one example. This is a patient, you see here the temporal pole, the thalamus, and the remnant of the hippocampal tail. The patient had a selective amygdala hippocampectomy, and this was the remnant. Patient had still a seizure, so what they did is SEG of the temporal pole and SEG of this hippocampal tail. And again, the hippocampal tail, the fasciolus in the rim, was involved in seizure generation to 100% extent. And what they did is they just repeated a lead therapy for this remnant instead of resecting the temporal pole. And this is the MRI of this patient, which is very interesting because in many series, and also myself, if a patient failed after selective amygdaloid lumpectomy, most institutions will then continue with temporal lobe resection. But in this case, they just selectively targeted the hippocampal tail, and the patient got seizure-free, which is, let's say, counterintuitive what we have learned from the literature on this, because it seems that in most of the series, it's critical to involve the anterior part of the hippocampus and of course the rest of the temporomesal cortices, but it's more important to have the anterior part of the hippocampus involved than the posterior part of it. What about the extent of mesal resection? As I've shown you, we have a lot of cortices involved in temporomesal epilepsy. And this was the first and the very nice study showing that, as you can see here, angle outcome scale 1 to 4, and then a percentage related to the cortex and area involved into the resection. And it seems very important to have the entorhinal cortex and the perennial cortex involved, as well as the amygdala and the hippocampus, to get a good seizure outcome. And more recently, there was this study saying that it's more important to have the piriform cortex involved. Again, you see this is the amygdala, this is the hippocampus, and this is the piriform cortex, and here the entorhinal cortex, and they did a very nice analysis, and this is the results and what they said. So in their series, it was not so important if the hippocampus was involved, or if the amygdala was involved, or the entorhinal cortices were involved in resection, but it was very important that the piriform cortex was involved, included into resection to get patient seizure-free. This caused a lot of discussion in the community, and this is then a paper 2 years ago where they selectively targeted the piriform cortex with SEEG. This is in non-lesional epilepsy, so this is not entirely comparable to hippocampal sclerosis patients, but still in this study, it seems, as you can see here, that the piriform cortex was not involved in most or in many of these patients. So, which is, let's say, the opposite of the paper that I showed you before. And again, extent of hippocampal ablation or mesal cortex ablation, it seems that it's important that the entorhinal and perennial cortex, as well as the amygdala, is involved to have a good seizure outcome. And then last, probably it's not all about the morphology, it's not about length and volume, maybe it's more about the extent of the network disruption that we need to face and to try to understand for our future studies. So this is a very nice paper, not reflecting hippocampal sclerosis, but temporal lobe epilepsy. And what they did is they did a network analysis before surgery, then a network analysis from the part of the brain that would be involved into the network, and then the network that is surgically spared. And what they were able to show is that if the abnormal nodes of this network were involved in surgery, then patients have a very good outcome. If there are a lot of abnormal nodes in the network that were not involved into the resection, then the seizure outcome was worse. And with this comes the issue of dual pathology when we talk about hippocampal sclerosis and selective resection of the hippocampus or the temporomesal structures, because as is known for a long time now, that in patients with hippocampal sclerosis, there is quite a proportion of patients that have another pathology involved. So this was the first systematic study on this in the early 90s. But also here in this pediatric series and in the pediatric population, this seems to be very important. As you can see here, MTS, mesiotemporal sclerosis, and focal cortical dysplasia. So dual pathology was much more often than mesiotemporal sclerosis itself. And probably this is also the reason why in many centers and in many meta-analysis, it seemed that in patients with temporal mesial epilepsy and with hippocampal sclerosis, anterior temporal lobe resection is receives a higher likelihood of seizure freedom than a selective resection, probably because this issue of dual pathology was addressed by doing a large resection. And this is also true in patients that got a selective resection and were not seizure free. So this is a pediatric series where anterior temporal lobe resection followed selective resection of the amygdala hippocambectomy. As you can see here, mesiotemporal sclerosis in 5 patients, they did an anterior temporal lobectomy, and all of them got seizure free. And also in our series, we did in 11 patients, we did an anterior temporal lobe resection following selective resection in patients with hippocampal sclerosis. And 8 of them, 72%, got seizure-free after the second operation. And with this, I come to an end and happy to answer questions later.
Thank you so much, Christian, for this exciting presentation. I'm pretty sure people have lots of issues to discuss after we finish with the presentation. It's my great pleasure to have Valeri on board from Bonn, and I would like to ask him to share his presentation and present on the extent of resection on non-mesio temporal lobe epilepsy. Valeri, welcome, and please go ahead.
Hello, everybody. Thank you for our introduction and having me today. So you have to allow it again to share my screen.
Okay, you're done.
So then, so it's okay, it works?
Yes, perfect, wonderful, thank you.
Okay, yeah. So yeah, my topic is the neocortical temporal resection, and the question is very important because it faces us every day or in our daily practice, and these how much should we resect? And my argument is the extent of resection should be dedicated by the underlying pathology and not a fixed technique itself. And I will try to show you, according to some clinical scenarios, why this question is so important. So when we look across the temporal lobe epilepsy literature, the reported seizure freedom rates range from about 35 to 80%. So we see a very huge a gap of 45 points for what we call the same surgery. And that usually means one of the things that we not doing the same operation or maybe not treating the same disease. And both are true, actually. And the label like neocortical temporal lobe epilepsy hides very different substrates. It could be a small tumor, subtle malformation, a skull-based effect, sometimes two together, like dual pathology. We heard about it already by Christian. And so the honest question isn't which operation is the best, but what the substrate is and how much of it we need to remove. So the drug resistant neocortical temporal lobe epilepsy, one question matters most: does the MRI show a lesion? And if yes, we are on the lesional pathway, and we tailor the resection to that lesion, and outcomes are higher and more predictable. And if MRI is negative, the extent becomes a trade-off between seizure freedom and neurocognitive costs. And our first job is to hunt harder for a lesion and what we haven't missed or haven't seen. And MRI negative doesn't automatically mean lesion negative, in my opinion, because a negative scan could be a start of a search and not the end of the evaluation of the patient. And so that it's an important thing to keep in mind. That it's not a soft preference, it's a quantified, because we know from the literature that visible lesion on MRI or histology carries roughly 2.5 fold higher odds for seizure freedom. And for temporal lobe epilepsy, especially, the odds ratio is around 2.7. And it means that about 3/4 of MRI positive patients became seizure free, versus a bit over half of MRI negative cases. And concretely, it means if we have two patients with the same seizure or same epilepsy duration, same disease, so to say, but the one is have a lesion and the other patient have not, so we counsel them very different on prognosis and how to aggressive the surgery need to be and so on. So that finding the lesion is probably the highest yield thing we do in the whole workup previous to surgery. And as Christian already says, the benchmark is the mesial resections or mesial temporal lobe epilepsy, because it frames everything. And in classic hippocampal sclerosis, the debate is selective amyloid lumpectomy versus standard anterior temporal lobe resection. And for seizures, it basically doesn't matter, because the two gives comparable seizure freedom. What differs is the memory, and when seizure outcomes is equal, we have to spare tissue to preserve patients for memory decline. And that is almost uncontroversial in the mesial settings. The interesting question is the neocortical cases, where extent of resection generally changes whether seizure stop or not. And so sparing tissue and stopping seizure pull in opposite directions. Newer data sharpen this aspect. So Ney and colleagues dissociated the two outcomes. In seizure freedom was essentially flat across posterior hippocampal extent, like shown in this SHRAM study. But verbal memory decline climbs steeply with it, and capping a dominant side resection at about 55% cut the odds of significant verbal memory decline roughly 8-fold. So, and seizure control was unaffected. And this echoing Helmstetter data from earlier ages in Bonn, who work on material-specific memory, and could also show that the resection of neocortical tissue is associated with a decline of material-specific memory. On the right side, more for figural memory, and on the abdominal side, on the left side, more with the verbal memory. So the through line is if seizures are largely extent insensitive, but cognition is not. We have let the pathology set the extent of resection actually. So if, simply said, is if there is no need to resect a neocortical tissue, we should leave it and staying on the selective procedure when only the mesial structures are involved. So this led us to the question was what are these neocortical substrates that are leading us to perform neocortical resections. I want to mention in my talk 3 of them, but of course there are much more. But here we can show all these difficulties to create a right setting for the right patient. So the first one is a temporal encephalocell. It's a great MRI negative mimic. And the second one is Borger. Is a malformation that looks focal, but often it is very widespread. And the third one are the low-grade tumors. We group as LAIRs, as gangliogliomas and DENET and so on. And I will take each in turn, but they are not the whole story, of course. Dual pathology with classical hippocampal sclerosis and with the focal cortical dysplasia, isolated focal cortical dysplasias, sclerotic scars and carcinomas are the other cases. They are made neocortical resection necessary. But for example, the dual pathology matters most, I think, because address only one target and seizure persists. And our real job in the workup is really to build a specific anatomical and pathological hypothesis and design a resection around the pathology that we have found. So let me start with the temporal encephalocell. Is maybe the one we most often miss in our workup. It's a herniation of the temporal pole through a bony defect in most of the cases, and in the middle fossa floor. And the MRI can look normal, and up to a third of them are found only intraoperative. But a dedicated skull-based CT shows the bony defect in about 90%. So it's very, very crucial to perform this imaging if we assume this pathology as a cause of epilepsy in the dedicated patient. And the temporal encephalocell mimics very good mesial temporal epilepsy perfectly. So surgery is favorable. It's actually resections encephalocell and overlying that temporal pole and spare the hippocampus, reaching around 75% seizure freedom without the mesial memory costs. So because we have not to touch the temporal mesial structures. And for negative MRI negative temporal lobe epilepsy that behave like a mesial disease, and so in these cases it's useful to get a thin slice skull-based imaging. And once we found an encephalocell as a source of epilepsy, we have to resist the reflex to add a hippocampectomy, and the pathology, because the pathology doesn't require this, and we get in the most of the cases favorable seizure outcomes. The other pathology is Borger. That's the opposite, actually, from the previous one. And the key point is, in this case, it looks focal, but frequently it is widespread. And critically is, for example, PET imaging, because it shows often more than MRI alone. So that the visible zone in MRI is smaller than the disease itself. And the outcomes in these cases are driven by completeness of resection. So we frequently go beyond the visible lesions under ECOG or stereo G guidance, for example. And the other resection leads in recurring seizures. So Borger flips the encephalocele lesson because the danger was doing too much, and here it is doing too little. So what come from letting a fixed idea of the operation override what the pathology is telling us, but it's why, especially in this condition, the PET and molecular workup earns a KIF. The third are the low-grade epilepsy-associated tumors, or so-called CLEADs. They are mostly gangliogliomas or DNETs, and they are very well defined on T2 or FLAIR images on MRI, and over 65% of these lesions are WHO grade 1, and the seizure freedom rates are in low to mid 80s. So, and the nuance is only the location, because for lateral neocortical tumors, lesionectomy and little corticectomy is enough. So we have to spare the mesial structure and protect memory. Of course, if the tumor involves the mesial structures, we have to extend and to add amygdaloprogrammectomy to our resection. And of course, previous discussed this with the patient and address so the right way to treat this this pathology. Now I want to mention one maybe underappreciated quotient or underrepresented area, especially in the dominant side resection, which extending or when we extend the temporal resection basally and posteriorly, we approach the mid-fusiform gyrus, and in the dominant temporal lobe, the visual Wolfram area, which is essential for fluent whole world reading, is mostly represented there. So it sits actually beyond the standard lobectomy margins and routine naming maps. The colleagues from Bethel Epilepsy Center, from Kloppenburg group, discovered this in their cohort and found that of 34 patients which had a resection on the dominant hemisphere, 44% had a postoperative reading deficit if this area was touching by or involved in the resection. And 6 of these patients were letter-by-letter readers, and 2 of them have had permanent deficits. So before a dominant site basal resection is acquired or is setting, we have to assess reading and map this area. For example, with functional MRI imaging. to try to spare the inferior longitudinal fasciculus fitting in order to preserve patient from this very very difficult deficit in which compromise their capability for reading or fluent speaking or writing. Now pulling it together into a practical algorithm, we can say that if there a lesion on an MRI for a lateral neocortical lesion, lesionectomy sparing the mesial structures are actually enough as an extent of resection. Of course, if the mesial structures are involved, there's a dual pathology, extent should be included the amygdala and hippocampus complex. For special conditions like Borger, we should try to address and to resect the whole malformation, maybe using ACOG or Serie G guidance intraoperatively. And if MRI is negative, the more thing is, I think, to do a real image and to hunt for the occult lesion, and especially like temporal pole and encephalocele or others. And so in these cases, we should stress additional comprehensive pipelines with multimodal imaging like PET and SPECT imaging, and of course underlie this patient to Serie G evaluation in order to define the epileptogenic zone, because that's crucial in this case, and can allow us to set the right extent of resection in the right patient. Yeah, that's actually the consideration that we have to take in account if we counsel the patient and decide which strategy of surgery we should use in every case. So actually we can say that the extent of resection of neocortical tissue should be addressed on the pathology that we have seen or we have detected, and to a special individual consideration and an individual characteristic of patient. And we have to discuss this with the patient, especially in regard of neurocognition and neurocognitive deficits. So they are the reference of my talk, and I have to thank all the people that are involved in every surgery program and our department and our corporations, and thank you for your attention.
Thank you so much, Valeri, for this great presentation. I think it's now time for discussion. I invite all the panelists to be there. I already see everybody. Let's just start with a question from the audience. Jiren is asking, I guess is related to your talk, Valeri, what would be the role of PET and SEEG in defining the role of the extent of resection in non-mesial temporal lobe sclerosis, non-mesial temporal lobe epilepsy?
Yeah, I think the Serie G evaluation is crucial, especially in MRI negative cases. So where we do not see dedicated lesion, and so we have to decide how much of neocortical tissue we have to take in our resection. So if we do theory G evaluation, we are able to on the other side to understand the whole network and to understand where the seizure that zone is, and then we can monitor with this theory G how much of neocortical tissue is involved in seizure or seizure propagation maybe, so we can guide it or guide our resection with these results of this theory G evaluation.
So Berto and Tatiana, would you please join the discussion?
May I I would like to comment, Valeri, a little bit about Moge. As I get it, Moge is quite a new diagnosis.
Yes.
And according to my opinion, it has mostly been found in frontal lobe. But anyway, it's very interesting when you discuss it in the temporal, because sometimes you say you see something, but some of the Moge cases, they are actually completely MRI negative. So it's an interesting group for the temporal lobe. And I think it's the first time I heard it discussed regarding the temporal lobes. So that was very interesting part, I think. How common would you say that you find Moge really in the temporal lobe?
Yes, we have so far 2 patients with Moge and temporal lobe indeed, and so you're right. First of all, the most presentation of Moge is in pediatric cases and in frontal lobe. It's true, but there are also some cases that are presented with Moge in temporal lobe, and particularly in these patients that we have seen in our department, it was younger patients with an early history of seizure onset. In this particular patient, it was at 1 year, and she was MRI negative for years. And then if we do perform some comprehensive imaging workup with MRI, 7 Tesla MRI, PET CT scan, and so on. So we seen some blurry on temporal lobe. So that it was not like FCD special or so there was some assume that it could be Moge, and with the steroid resection of the temporal pole and lateral neocortical resection, sparing to mesial structures, and it was about 3 months ago. And so far, the patient is seizure-free, but of course it's very, very short follow-up. So we have to see how.
Would you expect that Moge is restricted to the temporal lobe? I have sort of a bad feeling about Moge, that it might be much more widespread. Or do you have any comment regarding that?
Yeah, it could be. It's not only in the temporal lobe. It's also a multi-lobar disease. So we, but so far in this patient we didn't have aspects of clinical, at least for involvement of other parts of the brain. So it was very, very isolated temporal lobe epilepsy. So let's see. But of course, it has a risk that the resection is not enough. So it's
okay.
maybe.
Thank you. It was anyway very interesting to hear that discussion in relation to a temporal lobe dissection. Thank you.
Valeri, thank you so much for your outstanding presentation. And I was wondering, could you comment a little bit more about ECOG on lesional neocortical temporal lobe epilepsy? I saw you mention it for Moge. So
Yeah, it's actually the same thing to get, because we did not see our margin, how far we shall go to for the resection. And so the one possibility is use stereology data to guide these resections, not only in temporal lobe, also in frontal lobe, for example. And the other, so you can, to do this, you need, of course, a very extended temporal, extended stereology implantations with covering the whole network to get this idea where the margins are. And so and intraoperatively, of course, you can use then ACOG to show if you set up your margins and finish the resection, to show if there is some activity or not. So it's can guide you intraoperatively really to see did you catch your margin or not.
Do you have a rationale when you use one or the other?
Then there's this possible to extend your resection. You can do this, of course.
But do you have a rationale when you use one or the other?
Yeah,
SEG or ECOG?
Yeah, the intraoperatively we use mostly the ACOG, and stereology data we use in advance for the planning of the surgery, of the resection extent to set our margins. So that's the way to use both of them.
Okay, thank you.
And I'll comment for you, just Christian. I think it was last time also we discussed this with the piriform cortex, which I think is rather difficult in surgery to define, but anyway, it's discussed as a very important part. So it's interesting to see that sometimes piriform cortex pops up like the main seizure generator, and sometimes it pops up like not so important, but I think you commented on that also. Do you have any further comments on it? I would appreciate it.
Yeah, so I mean, it was a very controversial topic with the piriform cortex, and we had this discussion for the last couple of years. Yeah. But I really think in the end, I think where we are going is to somehow individualize our approaches and our extent of resection, because there are patients probably where it is more important to involve the anterior aspects of the temporal mesal structures, like piriform, like entorhinal, like perirhinal cortices, and it's difficult to resect the perirhinal and entorhinal cortex and leave the piriform cortex intact. I think that's very difficult to do that. Yes. And there may be other patients where it's more important to involve the posterior parts of the temporal mesostructures, hippocampus and parahippocampus, as this Nature Medicine study was showing us. And this is actually very interesting to me, especially the one patient that I showed after selective amygdala hippocampectomy, where they did SEG evaluations of the temporal lobe and the hippocampal tail, and saw that the hippocampal tail really was very involved in seizure generation, and they decided to just lit this posterior part of the hippocampus instead of doing a temporal lobe resection, which is very nice if this is successful, and this is this individual approach to the patients, because this was a left dominant temporal lobe. So if you decide to, there were no details on the patient's characteristics, at least that I can remember now. But if this is a high functioning patient that you resect the temporal lobe, you will give this patient a deficit for sure. And if you're able to define the extent of resection or ablation to the most critical parts, as in this case was the fasciolar cinerarium or the hippocampal tail, then that's very, very exciting. And I guess this is gonna be, let's say, the future discussions, how to individualize our approaches. And as Guy McCann tried to do it with intraoperative electrocorticography, which is the only, let's say, method that we have currently, really, at least to try to get a sense about intraoperative decision making. But we all know that intraoperative electrocorticography is, useful in some and difficult in the others. Let's put it like this. And in some centers seem to have very good experience in using electrocorticography. Other centers do not, and I think it's very up to experience in using this technology and experience in reading it. So there's a lot of bias that comes into all of these institutional experiences. And probably in the future, as I've shown you with this publication on network disruption, probably in future we will have hopefully a method, probably an imaging method or something like this, that we can measure the epileptic network and define the critical nodes, and then resect these critical nodes, hopefully, and not rely on just morphology itself, like the length of resection or the volume of the resection, but there is something more than just morphology, which is the connectivity. And we all know that we're talking the last decade or so about the epilepsy networks, and we know that epilepsy is a network disease. It's not something new, but with respect to epilepsy surgery, there comes the trade-off or the problem. We talk about a network disease, but all that we have in hand is resecting morphology, and this is then the difficulty to to put these two, let's say, worlds together, that we get the information from, let's say, basic science or translational science into a pragmatic epilepsy surgical approach in the end at the patient. This is something I think we need to work on.
Thank you.
We have a good bunch of questions from the audience, and so let's start with this first one to Valeri. How would, coming from Matthias Tomczyk, how do you differentiate between MOGI and focal cortical dysplasia in your pre-surgical workup and estimate the extent of resection is necessary? Is it how can you tell it's a MOGI beforehand?
Yeah, it's very, very good question. Actually, you can only do this afterwards, and to be sure that it's MOGA. But previous to surgery, there's some evidence that if stereo EEG evaluation is done in this patient, that MOGA have some specific so-called print or fingerprint electric activities. So if you get MOGA with your stereo EEG, you can identify this according to your stereo EEG signal, and you can also differentiate this with signal from FCD, for example. So we do some studies on this to get this differentiation. So that's the one possibility with stereo EEG monitoring, to differentiate if they are MOGA or other pathologies. And the other possibility is to isolate DNA from electrodes that are are lying in the assumed pathology and do sequencing and search for genetic mosaic, which is special for Borger, and then to get the idea if it is or not. That's the way to get idea previously to surgery, but of course it's very very difficult, very resource consuming approach, and otherwise just alone with MRI imaging or like this, it's very hard to get this.
Thank you. So another question coming from Faisal Alotaibi. It's I guess this is for you, Christian. In a patient with anterior temporal neocortical atrophy associated with hippocampal sclerosis and hazy white matter changes suggestive of heterotopia secondary to long-standing epilepsy, would you still consider performing a selective hippocampal resection, or would favor a more extensive temporal lobe resection?
So I would definitely favor a more extensive resection. So in our series from Vienna, this was a strict inclusion criteria, and to do a selective resection, that there is no whatsoever change on the MRI suggestive of a dual pathology. So this is really hippocampal sclerosis and nothing else. And if there is changes, so white matter blurring or atrophy of the temporal pole, then I would definitely go for a more extensive resection.
Thanks, Christian. I have another one from Matthias Tomczyk, and that's for you, Christian. What the cognitive effect of lesioning the fascicular scenario would be when the posterior pathways of the hippocampus are disconnected? Any guess on that?
So with regard to memory deficits and memory outcome, I think this is the most tricky part of temporal lobe epilepsy surgery. And I think that the theory to just do a partial resection of the hippocampus to hope to spare memory function, I do not believe in this. I think if you resect the hippocampus to an extent, then you will have a memory deficit, and it's, at least in my opinion, it's not dependent on the extent of the hippocampal resection. I think if you resect 50%, 60%, 70% of the hippocampus, does not matter with regard to memory outcome. The literature and the opinions on this are, let's say, different, but this is my experience, I would say. And with regard to the hippocampal tail and the fascicular cinerarium, I do think that, as was presented in this paper, if you are able to identify and then lesioning this most posterior part of the hippocampus, and do this instead of resecting the temporal pole, then you have won, if you want to. So, and I don't think that this is that this most posterior part of the hippocampus is so critical for memory function.
Thanks, Christian. There is a question from Ahmed Najar. Guess to you, Valeri. Are any proven benefit of awake craniotomy in dominant neocortical temporal epilepsy?
Yes, there may be some advantage to do this, and patients with lesions around Wernicke area, for example. So you can do this, but the problem is in epilepsy patients, they are often they are not really really good candidates for awake surgeries. So because of many things, because of fear, of other aspects. So which way to overcome this is, for example, to map function with series G around the lesion, and use this information for planning the surgery. And so it's going to be an approach to get some good estimation regarding the function in these relevant areas, and do a sleep craniotomy, also surgery, but to know where the function is and where the safe corridor for the resection is. So we try this in some patients, but it's not that much big cohorts of them, and in those where we try this, it worked very good. It's maybe one approach to do some functional guidance with a series G evaluation, and to use this for the resection. But of course, if that's not possible, and there's the elegant function is very closely to the lesion, it's would be performed as a leg surgery.
Thanks, Valeri. There is another question now coming from Kenji Bayashi for Christian. Do you routinely implant electrodes targeting the piriform cortex during SEG? And if not, if it's tailored, when would you choose to implant the piriform?
So we do not routinely target the piriform cortex with our SEG in the past, and also not after this whole discussion started. So we still have our, let's say, traditional electrode positions in the hippocampal head, body and tail, and the amygdala, and do not selectively target the piriform cortex, simply because we, or I, do not think that the piriform cortex itself is so critical or more critical than all of the other structures involved, at least in my experience. And the second question was,
when you do like to implant, if you don't implant in everybody, is there a patient that you're saying for this one we need piriform coverage?
So there is no specific semiology or no specific clinical presentation of a patient where I would say this is a patient where I need to evaluate the piriform cortex. We do SEG in patients with MRI negative temporal lobe epilepsy. So in a patient with hippocampal sclerosis, we do not do SEG in any of them. Very, very rarely if there is a specific question about it. But if you have hippocampal sclerosis with a typical semiology and typical appearance on MRI, there is no need to evaluate the patient with SEG, at least in my opinion.
Thanks, Chris. And Valeri, you would like to join this discussion? I see your hands up.
Yeah. I want add some comments on this, because we do indeed implant routinely SEG electrodes to piriform cortex, and our observation is that how Christian said, piriform cortex is not this region of seizure onset. It's more propagation region which works like a hub for seizure propagation, and not as a region with source of seizures. And the whole thing about the resection of piriform cortex is actually this region has to be to resect. If you refer to the techniques of Wieser and Yajagil, you have to resect this portion of temporal lobe. But sometimes it is not that easy to go there and to get this region, especially maybe in selective procedures. So there's some possibility to leave some of tissue there in around this area, and in the end is maybe the goals of them is that the temporal lobe is not really selected from the frontal lobe, for example, because there is some connection. The peripheral cortex have some temporal part and then frontal part, and maybe it's work like a hub region to connect temporal lobe with the frontal lobe and with the whole other areas in the brain. And if you leave this connection, so the temporal lobe is not really disconnected completely, maybe that's why the seizure outcomes is not the best in these cases where much of them are leaving there. But actually it's have to be resected. So if you do a temporal resection, we attempt to resect this completely.
Okay, there is another question from Jiren related to encephalocele. So if the PET in a patient with encephalocele shows involvement of the mesial areas or the hippocampus, what should the resection margins be? How to determine whether the hippocampus should be included in the resection in a patient with encephalocele? And maybe I could add another question, very related question, which is encephaloceles are common, right? It's not it's an infrequent finding. So can you tell when an encephalocele is epileptogenic or not? So 2 questions. How can you tell if this encephalocele is the responsible, and then if there are PET involvement outside the encephalocele when you remove the hippocampus in these patients?
Yeah, when you have a patient with a temporal lobe epilepsy and do not see any other lesion there, and no lesion in mesial structures, no lesion neocortical. So we do this evaluation with thin slice imaging and MRI and CT scan, and if we have found encephalocele and there's no other lesions found in this case, and patient have isolated temporal lobe epilepsy, we do perform temporal pole resection, sparing the mesial structures, and then observe the patient afterwards and decide. The most cases that we treat with this setting are seizure-free. So there's
And when would you resect the hippocampus in a patient with encephalocele?
Yeah, actually there's no need to do this. If the hippocampus looks normal and MRI and there's no involvement of hippocampus, or there's no assuming that it's sclerotic or there's no other lesions, sparing the hippocampus.
Thank you so much. So, Christian, when you decide in a patient with mesial temporal, another question from there, with mesial temporal sclerosis to do a full anterior temporal lobectomy, how you define the posterior border of your cortical resection?
Yes. So
and the concomitant question for this is if you use the electrocorticography in these patients.
So answer to the second question, no, I do not routinely use electrocorticography in these patients. And for question number 1, The question number one, sorry.
How do you define the posterior border?
The posterior border. So, generally speaking, if you are facing a non-dominant temporal lobe, the posterior border is more far behind than in a dominant. Usually, I do on the non-dominant temporal lobe, I do 4 to 4.5 centimeters, and on the dominant temporal lobe, I do up to 3 centimeters as a plan. But then really I also decide this then intraoperatively, because very often you have a large temporal draining vein that defines your posterior border. And even if this if this vein would be involved into my resection, I would go anterior to this vein. I do not want to coagulate a major draining temporal vein just to make sure that I reach my 4.5 centimeters, so to say. So I really do this based on the individual anatomy also, but generally speaking, non-dominant temporal lobe 4 to 4.5, dominant temporal lobe 3 to 3.5. Not these 5 to 6 centimeters that is usually referred to as, temporal lobectomy.
Tatiana, I saw that you would like to join the session.
For the encephalocele, how far posterior you go for resection? How do you define your posterior border?
Me?
It's
both of you.
Yeah, it's mostly 2.5 centimeters or maximum 3 centimeters. So that you have the corridor to go to the temporal lobe to disconnect the cells from the bone, and try to spare, to leave amygdala and hippocampus intact. So that's its strategy.
Yeah, so I think this temporal encephalocele entity as a major driver of epilepsy is something, let's say, quite new, where we need to learn a lot more, I think, because as Arthur said, there are a lot of patients where we see these temporal encephaloceles when we do other surgeries as well. So they are not per se always epileptogenic. And then there are many factors that needs to be dissected in decision making in these temporal encephaloceles. Again, dominant or non-dominant, duration of epilepsy, again, seizure semiology, because if seizure semiology is pointing towards mesotemporal lobe epilepsy, even if the hippocampus looks normal, it's hard just to resect the encephalocele alone. But there are cases, of course, where you can do this. And again, if you're facing a dominant temporal lobe in a very high functioning patient, I'm the first to say, let's do the least invasive approach first, because we do not really understand the disease so much. So whenever I do not understand a disease to its fully extent, I try to be as minimal invasive as possible. So trying with a less extent of resection, and then if this is not successful, and that's all about patient counseling again, and if this is not successful, you can come back again. But if you have resected a dominant and functioning hippocampus, you cannot put it back again.
And
for the sorry.
Go ahead, Tatiana.
For the non-dominant side, how do you decide if you're going to resect the hippocampus or not, if seizure semiology may involve the mesial structures?
So I would say this also is that one major factor is duration of epilepsy here.
Okay.
So real duration of epilepsy, because sometimes if you elaborate your patients very well, they may say, well, like 20 years I have this, episodes, and now retrospectively, I think this is this might have been seizures already. And if you have a very long duration of epilepsy, let's say 20 years, and you are on a non-dominant temporal lobe, and the seizure semiology is mesial as well, then I would be more intended to do a larger resection and involve the temporal mesial structures than to do a small resection. Again, because if I believe that if I am involving the temporal mesial structures, hippocampus and the rest, that the morbidity of the resection is not too high. So again, there comes the critical aspects in the evaluation, about the functional status of the patient beforehand, and if there is a lot to lose, and what the patient is doing to earn money, and all of these, fine tone in quality of life that you may alter or not.
Thank you.
Let's follow up on. Would you like to join, Berta? The mic is off.
No, I have no really further
Ah,
comment.
okay.
It's still very interesting, especially also a little bit new to this encephalocell discussion, really. But it's very interesting to hear you discuss this.
So let's follow up on this topic of dominant temporal lobe epilepsy with normal MRI from some of the questions around the audience. And you've shown that if your patient had normal MRI and left dominant hemisphere temporal lobe epilepsy, that if you resect the hippocampus, you get a deficit. And if you resect the cortex, you get a deficit. So are these patients candidates for any type of ablative or resective procedure if they have normal neuropsychology, normal MRI, and temporal lobe epilepsy, or are they candidates for neuromodulation?
Should I answer, Valeri?
Yes, please.
Yeah.
So
it gives Valeri a minute to think about it.
So I would say these are perfect candidates for neuromodulation, again, because I would say that's the less invasive approach. And it also depends on the seizure burden, of course, and what you can achieve for this individual patient in his or her individual situation. So there's a lot, again, this fine tone. But these patients, I would say, are perfect candidates for neuromodulation because the risk to have a memory deficit or language deficit or whatever is far less than with any resection that we can offer.
Sorry?
Yeah, yes. On the end, you have to discuss this with the patient, and you have to offer them all the possibilities. What the resection costs in regard of neurocognition, regardless, even whether lobectomy or selective procedures or other procedures, and of course, neuromodulation is one possibility with lower chance for seizure freedom, and yes, when the price is too high for this particular patient, if we do a resection in regard of neurocognitive function, that of course we can go for other options which less risk in this regard. So it have to be to discuss with the patient and choose the more or less personalized approach in all these cases. There's no general rule to say we do no resection or no other stuff. So it's up to the really case constellation.
And I think this also holds true for lead therapy, because
Yes.
it doesn't matter if you resect or ablate, the tissue is destroyed. So, of course, if you do a lid, it's minimal invasive. But again, if it's dominant temporal lobe with no lesion, then it doesn't matter how you destroy this temporal lobe and which part of it. If you do it minimal invasively or with an open resection, the effect is the same. Maybe with the lid, the collateral damage is less if you go for a selective resection, but I guess very few people would do a selective resection in this situation as well.
Thank you, Christian. I so much appreciate this discussion about minimal invasive, because as you all know, who have heard me before, I'm a little bit sort of opposing when you always discuss minimal invasive as a small hole in the bone or small opening. But you say even if you have a very small drill hole and you destroy the hippocampus, it will stop work. That's for sure. Thank you.
So thank you all. We have just a couple of minutes. Maybe Tatiana and Bertie, any final insight into what we've discussed?
I just must say, as for Valeri Borger, I think this discussion with Morgan, so it was so interesting because it's a little bit new anyway to me. And regarding you, Christian, you know, I always enjoy your excellent anatomy and excellent video clip. So thank you, both of you.
Yeah, I'd like to mention that I definitely agree with Christian when he said that probably connectivity is one of the main aspects to understand what we're dealing with and try to tailor the resection and improve the outcomes of our patients. So we need to understand a little bit more what we're doing to try to optimize the therapy.
With this, I would like to thank everyone for sharing his thoughts and the audience to fully participate with lots of questions, and to tell you and mention that the next webinar would be on August the 2nd, and we are start approaching extratemporal epilepsies, frontal lobe resections, and posterior quadrant resection. So I would love to see you back for our next webinar, and have a great rest of the Sunday for someone, or beginning of the Sunday for another ones. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
See you.
Thank you.